But before I introduce our speaker, let me go over some housekeeping issues. We continue extending CME credits for our tech talks and our ID series presentation. We will distribute the information via email to those that registered for today's event. If you did not register prior to today's talk, you can still obtain CME code information from Deborah Rees, and her email address is posted in the chat box. Do not miss our next ID series seminar on October 13th. Greg O'Neill from Christiana Care will discuss advanced teach-back skills in relation to the Health Literacy Month, which is October. So again, I'm really very excited to have Dr. Bowen here. Dr. Bowen is Associate Professor at University of Delaware in the School of Nursing, as well as a Research Health Science Specialist and Core Investigator at the Center for Health Equity Research and Policy in the VA Medical Center in Philadelphia. She obtained a PhD in sociology with a focus in gerontology and race and social policy from Virginia Tech in Blacksburg. And she was also an AHRQ postdoctoral fellow in the Institute of Gerontology at Wayne State University in Detroit. She did also a fellowship in patient safety at the James Haley Veterans Hospital in Tampa. Please mute all your microphones, please.
What did I have?
Please mute your microphone. So Dr. Bowen did a fellowship in patient safety at the James Haley Veterans Hospital in Tampa, and she has been continuously funded in the last 10 years to study physical function of chronically ill older veteran populations. She's an expert in measuring and predicting physical function changes in the elderly and has received multiple honors, last one in 2021 for outstanding research performance at the Department of Veterans Affairs, as well as for excellence in teaching at University of Delaware. She has multiple peer-reviewed publications. She's a teacher, a mentor for graduate students and junior faculty, and has served on multiple dissertation committees. So Dr. Bowen, thank you so much, and we are really honored and very excited to hear about your research.
Thank you so much. Hearing that all in a paragraph makes it sound like it didn't take as much time as it did. I'm delighted to be here, and thank you for asking me to talk a little bit about my research, which I'm very passionate about. I think for bandwidth, maybe I will turn off my camera and then I can turn it back on at the end when we have some question and answer period. So that was a great introduction. My research is funded largely by the Department of Veterans Affairs, and it began with a Career Development Award. I focused on the methods and measures of function using objective sensor technology data. I currently have a VA Merit Award where I apply these sensor methods and measures to examine how subtle changes in motor behaviors or ambulation and other factors associated with function may be able to predict acute events, and I'll talk a little bit about what those are. My scientific work also has a research translation and implementation science focus. I'm implementing evidence-based practices across 9 VA medical centers and 45 community-based outpatient clinics right now throughout VISN 4, which is Philadelphia, Pennsylvania, Delaware, New Jersey, a little bit of Ohio, a little bit of New York. And the goal of this latter project is to make the VA an age-friendly institution and improve the function of our community-dwelling veterans to help them stay in place as they age. So today I'm going to focus on the first project and using sensor technologies to capture changes in function and talk a little bit about how this work could be used to provide optimal care to older adults. So I define functional status really broadly in this work to not just be about activities of daily living, ADLs, or IADLs, but also things like gait, balance, upper and lower body strength. Of course, a lot of the ADL tasks require some level of cognitive ability to perform, so I also incorporate cognitive function in a lot of my measures. And an acute event such as a fall or urinary tract infection or delirium, is detrimental to older adults in long-term care. And it can affect their ability to perform activities of daily living. And these underlying physical and cognitive trajectories change as a result of these acute events. So understanding functional status in this way, very broadly defined, is critical in allowing clinicians to provide optimal care. We really don't do that well. We don't have a lot of assessments of function, and we don't do them early and often throughout the care process in long-term care. When we do identify functional impairments, we can engage occupational therapy and other interventions and treatments. We could tailor care plans and have major benefits for older adults in their daily function and quality of life. So understanding functional status plays a key role in evaluating the tolerability and feasibility of many of our interventions, assessing prognosis, and engaging patients and caregivers in the discussions about their needs for assistance, care planning, and goals of care. And then on a bigger level, health systems also benefit from understanding functional status. This can be used to anticipate the need for services and to understand patterns of health services use. I didn't say so, but if you have any questions at any time, I'll try to be also monitoring the chat to clarify anything, and then we can also chat at the end. So I'm going to be talking about one specific technology today, a sensor technology. This is actually not designed for humans or patients. It was designed to track car parts in BMW facilities, but it's an accurate system. It's called ultra-wideband radio frequency identification, and it meets all the requirements that we would need for tracking people, because you can track multiple people at the same time. You can track them indoors. So that's one of the issues with using GPS or something like a phone or a watch. You can track them within 6 centimeters. And the participant would wear a wristband sensor, and that would provide X, Y, and Z coordinates of location as they move throughout the unit and facility. So you have real-time, 24/7 continuous monitoring of their location and movement. And with this coordinate data, you can get a lot of different measures that can represent aspects of function. And like we talked about before, this could be related to gait, balance, cognitive status, or how they go about participating in activities of daily living, which is really interesting because this is their home. So in long-term care, this is where they live, and you're actually capturing what they're doing when they're doing it as they go about participating in normal activities. You're not looking at them in a lab and asking them to do something. So that's one of the reasons I like this type of objective sensor device. So I'm going to talk about some of the findings and results from 3 VA community living centers, which are skilled nursing centers in the VA, and they are located in central and eastern Pennsylvania. The team and I collected data continuously 24/7 for up to 2 years with this ultra-wideband wrist-worn sensor system. And I'll also talk about how this work applies to other patient populations, because I have utilized these methods and measures in a polytrauma TBI unit, assisted living facilities, and even with older adults in the community. So along with this sensor data that's being continuously collected, we also collected more traditional paper and pencil tools. We did this bi-weekly, so twice a month for each participant, to measure functional status in a comprehensive way. So if functional status includes all these components, not just ADLs, but gait and balance and cognition, then we need to capture that in our assessments. So we used the Montreal Cognitive Assessment to measure cognitive status. This was measured at baseline and every 6 months because it's not changing that often. But then we used other assessments like the Physical and Cognitive Performance Test, which we actually developed just for the skilled nursing environment. And it captures physical and cognitive domains. And we used the Tinetti Performance-Oriented Mobility Assessment for gait and balance. We also included the Barthel Index. We used components of function and cognition from the Resident Assessment Instrument, which is being collected there locally, and the FIM. So we have a lot of measures in addition to our objective sensor data. So we're most interested in understanding how we can capture function. What does function mean? And when does function change and how can we get ahead of it? Can functional status changes provide earlier recognition of an acute event that we're really interested in? So here, the older adults in skilled nursing have a lot of falls. They have urinary tract infections, pneumonia, flu, other respiratory illnesses. Obviously COVID was detrimental, and delirium. So we're trying to capture these changes in function as they may relate to some preclinical event like delirium, UTIs, pneumonia. I also utilized the confusion assessment method, the CAM and the RAS, to assess delirium. And we, of course, reviewed the medical charts to collect information on when they fell, were diagnosed with a UTI, pneumonia, flus, and all other illnesses. So this just gives you an idea. Hopefully it plays. I didn't. Uh-oh. Well, it was supposed to give you an idea. Maybe if I click it on my other screen. Look at that. To give you an idea of what the data looks like as it comes in through the system. So it's a bunch of gobbledygook until you run it through jitter and noise and you try to figure out what you have. But in here is a de-identified, participant ID and a XYZ coordinate. And this is really what all of our information is based on. This is just a few seconds of someone being tracked. You get up to 6 times a second per resident. So it's really a lot of big data. With these coordinates, we can do a couple of different things. We like to do visualizations first to kind of see what's going on, who's really active, who's not very active, what times of day people are active. There are all kinds of applications with this. If you're looking more at like the larger health system kind of level, you could track workflow, you could track, med timing, and, we have barcodes and things that we're using with patients to do some of this already. But you can also visualize where people are within a blueprint of the facility if you wanted to for location and tracking. The clinical staff really like this because locating and understanding where people are has been one of the most useful things that they got out of this. It was one of the earliest functionalities, and they really liked that they were able to pull up everybody and figure out where they were. But we're going to talk about some higher level applications too. So I wanted to take a step back here because finding a sensor technology that can measure what you need is really just the beginning, because you have to translate this X, Y, and Z data into something meaningful. And if we're trying to translate it into functional status, that's really big. So we need to map out how to relate these to our more traditional functional status, gait, balance, and all these other assessments that we're used to using. So to do this, we first analyzed 142 pre-recorded videos of nursing home residents, and we coded their behaviors. And then an additional 12 nursing home residents were observed in the environment for 2 weeks at random to capture the morning shifts, the afternoon, evening, and even night behaviors. And we were looking for ways that we could use these location coordinates to describe behaviors and patterns that were in the literature that would suggest some sort of increased physiological vulnerability. Because remember, we're looking for some early signal that something's going wrong, and it could be delirium, it could be UTI, it could be a cognitive status change. And so some of the measures that you see here were used to conceptualize continuous walking, which most people are familiar with wandering behaviors in long-term care. So we also looked at deviation from a straight line, which is called tortuosity. So the more random, the more turns you're taking, maybe the more confused you are, maybe you're in pain, maybe you have some other issues. So it could be associated with dementia progression, and lapping and pacing patterns could indicate another acute event. So we first had to visualize this and code these behaviors before we could then take the next step and figure out how to translate those XYZ coordinates into behaviors of interest. So this kind of shows the beginning of how we began to translate those. It shows how we conceptualize these ideas and how the XYZ sensor data could be used to represent different aspects of function, including activities of daily living, gait, balance, cognition, and other underlying cognitive and physical domains that we were interested in. So the path characteristics here are continuous or sustained walking that we talked about earlier could be associated with wandering episodes. One of the issues with this type of objective measure is that you really don't know why the person is doing what they're doing, and you don't know if they are following a staff member around the unit. So maybe it looks like they're wandering, but they're really following the med cart. Or maybe it looks like they're doing something else, but it's really within another patient, it wouldn't be of concern because they always do it. So that's one of the challenges between being able to go and observe and code the behavior. You can understand the stimuli. Oh, this is what's happening. They're getting, this snack that they always get, or they're following the med cart. But when you have this data taken out of context, sometimes you really cannot. So really what you start to focus on then is changes within that particular resident over time to kind of think about something could be wrong with this person. There could be something that we need to assess. Then we also have some metrics in here associated with physical activity because we don't want these older adults to stop walking. If they're, even if they're wandering, if it's beneficial for them and they're not getting tired or fatigued, that is a physical activity with a time and distance that is good for them. Maybe they're at a healthier gait speed, and we would want to encourage that behavior and certainly not restrain it. So when we get these data, there is quite a bit of additional transformation that has to happen. And we smooth it and we reduce the jitter because when you look at the raw data, by the time the sensor catches up with the person or wakes up, notably, we did not put these sensors in patient rooms. So they would go to sleep. And if the patient got up and they were really a slow walker, which a lot of these folks are, it would take some time for the sensor to see the wristband out of their room and catch up with them. So you see this person walking back and forth and they look like they're going through walls. So we have to account for that. We have to do some additional transformation and smoothing. And we just use a 5-second moving average time window for that to make it consistent with their actual movements. Our statistical analysis with these data takes on more traditional statistical types of analysis, and then we've more recently gotten into machine learning statistical techniques to analyze our data. So we've looked at growth curves to account for our data that's nested within persons over time. And this has been really useful because I'm going to talk a little bit about our clinical interviews with staff, but one of our most important findings is that just saying lapping is associated with an acute event, or wandering is associated with an acute event, or this type of behavior is associated with gait or balance, and that predicts an acute event, doesn't really work. What these older adults have multiple issues, and they all look different. And so really what we learned initially is that the best control is themselves. So thinking about what does their normal behavior look like, and how can we use that to model going forward to pick up any changes, has been the best measure so far. Now that said, we can still say in general these three characteristics are associated with a fall, but there's some folks with really bad balance, really poor gait. There's some folks that move very slowly, and that does not always predict an acute event because that's the way that they've always walked and is not a change for them. So we've also used machine learning like random forest, partial least squares, and linear classifiers to identify additional predictive factors and physical activity and other ambulation patterns like lapping and pacing patterns to improve our predictive capability. And I'm going to talk about this in a bit. So I mentioned that these folks had multiple comorbid conditions, and you see they have on average over 5. They are largely white, which is consistent with the population. Their MoCA scores are consistent with cognitive impairment dementia. We didn't have stairs in the facility, so the score on the Barthel goes up to 90, but you can see that they have some ADL, activities of daily living issues in bathing, eating, or dressing themselves, which is what you would expect in a nursing home population. And they also have some gait and balance deficits as well. So the gait scale on the POMA goes up to 12 and the balance goes up to 16. This is one of the findings from a sub-study that we did with only 23 residents. And here we monitored them with the ultra-wideband technology, and we conducted all of our biweekly paper and pencil assessments for 18 months. So this is continuous 24/7 ultra-wideband collection in 2 skilled nursing facilities. And during this time, we had 40 falls among 10 unique residents. So we had, repeat fallers, 5 delirium events among 4 unique residents, and 7 urinary tract infections among 4 unique residents. So this table is just to kind of show the variation in, and this is in meters, the variation in meters walked, the time that they traveled in seconds, and their continuous walking, which we call paths, by the total sample and then by the acute event. So remember that paths are kind of like wandering, and we define that as a resident walking for at least 60 seconds with no long pauses. They're not stopping. So they're walking for at least 60 seconds. They're not stopping for at least 30. They're continuing, so they're not stopping to eat or to rest. So an increased number of paths mean more of this continuous walking, but not necessarily the sustained walking for long periods of time. And when we explore this further in our statistical analysis in a growth curve model, we found that falls are associated with decreased gait speed and path distance, and that delirium is associated with increased distance traveled, path distance, and decreased time traveled and path time, and that urinary tract infections were associated with increased distance traveled, decreased time traveled, and decreased number of paths. So we were getting the idea here from these growth models that there are multiple factors probably influencing each other that we can use combinations of these factors to better predict these acute events. So that was our theoretically driven model where we took the information from our observations and our codes of what they're doing. We use that to inform how we developed our measures with our X, Y, and Z coordinate data into paths and time and distance traveled and all these different measures. And we really drew that from the literature to think about how folks in these facilities ambulate, what that looks like. Gait speed is really important in the literature. So that was more of our theoretically driven model with our growth curve analysis. Then we wanted to look at machine learning techniques to explore different models and more data-driven models, which kind of it can open up a big black box because sometimes you aren't sure why you got what you got. But we used unsupervised deep learning models, and we classified the data into 5 clusters, and those were significantly different from each other. And the clusters were sedentary behavior, semi-sedentary behavior, direct walking, so that's like there's a point A to B and you walk directly there. Sharp turns, or this tortuous walking, kind of like the random ambulation that is in the literature for wandering, and many sharp turns, very tortuous walking. These motor behaviors were classified in 15-minute intervals for every single resident, and this study was over the course of 18 months. So the ROC curve on the right shows that these classifications were sensitive and specific to the acute events of interest. So falls, delirium, and urinary tract infections 1 week prior to the week of the event with pretty good sensitivity and specificity. With the highest accuracy in the models that utilize these classifications of sensor data, when you use other factors like age, wheelchair, and our assessments of the Barthel and the MoCA. So the main takeaway here is that the machine learning models we were able to conceptualize some additional measures. It makes sense because these folks are very sedentary in these facilities. But then we were able to connect it with the literature in terms of tortuosity, wandering, and even physical activity, because the direct walking should be promoted, right? And the main takeaway from the ROC curve is that the prediction becomes much better when you utilize not just the sensor data or the chart data or the assessment data with the Barthel and the MoCA that we had, but when you combine these together, you have a much more sensitive and specific model to predict these events within a timely, I think, clinically relevant time period. So just to talk about some of our other findings, we've looked at predictors of activities of daily living and acute events also in assisted living facilities. Here, the path characteristics and wandering episodes are about the same type of measure. And this is the number of times that they walked continuously in those paths for at least 60 seconds without stopping. Wandering in the literature is shown as, it's usually conceptualized as a bad, hazardous type of activity because the person doesn't stop to eat or to rest, and they eventually fall or have some other bad outcome. So we knew that wandering is associated with poor outcomes, but we did find that increased wandering distance was associated with decreased activities of daily living, but that they could also be beneficial for your activities of daily living. So there was a threshold, there was a tipping point. Wandering is not always bad, and it was not always a behavior to be curbed. It was a type of physical activity that, if restrained, would decrease function in this population. So in this study, we discussed with clinicians how to recognize wandering, which really was unrecognized until the resident wanted to leave the facility, which is elopement. So at the time that they wandered so much, they found a door and they tried to leave. That's really when the activity would be noticed and curbed. So we talked with clinicians about, this is wandering. How can we do some ongoing assessment for fatigue and other physiological needs, that we could limit the distance walked, maybe distract with a snack. If you notice your whole shift, somebody's been doing laps, maybe it's time to, and they're missing lunch, take their hand and walk them over, provide them with a snack and some water, and then let them go again. So figure 1 shows balance ability in particular influences the ability to wander. It's associated with sustained walking for longer periods of time. And so balance interventions could be a way to get more older adults to sustain that good beneficial walking. As figure 2 shows, too much of it can be bad and is associated with a fall. And here everything is standardized over the course of 5 weeks, but you can see the uptick in distance that's associated with that imminent fall. And older adults with dementia or severe cognitive impairment experience that uptick up to 4 weeks prior. The trend is especially significant for them. So we're also looking at how to pull known patterns out of our data. So instead of just using the XYZ coordinates to create time and distance traveled, tortuosity, wandering, and these other measures, looking at the types of patterns that people are making. And these patterns are especially difficult for clinicians to detect, but we know they exist. And we know that some of these patterns are indicative of a dementia progression and possibly other acute events. They could also signal pain, which is, something that couldn't be communicated by the older adult, but would be related to urinary tract infection, for example. So we use supervised learning to extract these patterns from our data, and we're currently in the process. We were successful with that, and we're now currently in the process of analyzing how these may predict outcomes interestingly enough, we did not find a lot of lapping in our data, and that could be, we hypothesize that is because of the institutional layout of the facilities, not that the older adults aren't doing it, but in these facilities that have long hallways with less space to walk, that behavior is not very common. So we're working on translating these findings to the healthcare setting and getting it to clinicians. And with that goal, we interviewed clinicians in these settings, and we presented them with the real-time data from our studies. We gave them the sensor data alone. We just showed them, you know, here's somebody walking around. This is what it looks like. What do you think is going on? And then we were really interested in understanding what they would do with this information. Or would they continue to monitor it? Would they report it up to their supervisor? Would they go do eyes on the patient? Would they do a formal clinical assessment? What would they do? One of the interesting findings was that the clinicians focus first on understanding who that patient is. So when we show them a facility layout, they first try to guess if that's their facility. And if it is that their facility, they try to guess who the patient is. And then based on who that patient is, they make this determination. It's almost like they have a behavioral phenotype. They make this determination of whether or not this behavior is pathological. So if it's in their facility and they've identified it as Bob, they say, no, it looks like that they're participating in tortuous random walking, but that's just Bob. And it says, you know, it's this time in the day and he's going from his room to get coffee, and then he'll do this, and then he'll do this, and then he'll do this, and this is not pathological, this is normal. So again, I think stressing the point that each resident is different, they have their own patterns and behaviors, and understanding what is a change for them and what is not is really more of an intra-individual instead of inter-individual kind of assessment. So a lot of the time was spent on determining if the behavior is clinically significant or not. And so we learned that we have to put this data in a context for it to be understood, and that the clinicians utilize their context, everything they know about that resident, which is a lot, they utilize that context for decision making. So an older adult with a urinary tract infection, it might be missed if there are subtle changes in their behavior that the clinician's not picking up on from their routine until, you know, they start laying in bed more and it's noticed that they're missing meals, and then someone realizes that there's something wrong with them. So these types of understandings of each patient, they are subjective. They're based on a lot of information that the clinician knows, but really there's an opportunity here to provide some additional objective information for clinicians to use to understand when there really is something wrong. There was a lot of confusion in these focus groups about what to do next because there was a level of uncertainty. And so some of the clinicians would say, well, I would just wait 24 hours and check on them again and see if they were still doing it. They didn't really think that they had enough information to say, oh yes, I'm going to report this up. This needs to go in there right now. So I think some standardized procedures with objective data would really help in these settings because this would help inform some of their clinical decision making. Oh, wrong screen, hold on. I wanted to play a video for you, but it's not. So this is an example, if you look, this is a facility layout, and this is an example of what I was talking about earlier with the clinicians and their decision making. So in one particular, and it is 4 a.m. in the morning, one particular focus group, and they were interdisciplinary. We had everybody in there from directors to charge nurses to restorative therapists, physical therapists. Everybody was in there. And if this was their facility, they would say, oh, this is so-and-so, and they would provide a rationale for this type of behavior. If this wasn't their facility and you explained, you know, oh, here's an exit, and it's 4 in the morning, then it became pathological. Oh, this person shouldn't be up at 4 in the morning, and they're wandering around and they're exit seeking. So the first group, however, would say, oh no, I know who this is. He can't sleep. He always gets up at 4 in the morning, and this is actually our custodian going to each room and providing clean towels for the morning. And he follows the custodian. And if you have, and if you played it a little bit more, you'll probably see him change from the exit to go back around the hall and come down the other hall because that's where the custodian goes next. So again, just reinforcing the idea that these clinicians really know the patterns and behaviors of the residents, and that context is really important. So to sum up, we found that changes in functional status, no matter how you measure it, the gait, the balance, activities of daily living, those changes are subtle and they're difficult to detect. They are within a context, and so you have to know a lot about the resident to understand when there is a change. We found in focus groups that some changes in behavior are unnoticed, and they're difficult to distinguish between day-to-day variations in behavior. And there are also diseases, comorbid conditions, age-related decline, cognitive decline, dementia will cause huge variability day to day. And it really is difficult to understand, is this resident changing in a way that I need to act, or is this resident experiencing a bad day with dementia? So even when the behavior isn't subtle, we also found that it could be missed. We had one resident who walked 23 miles. We knew because we went back and looked at the data over the course of 1 week, which was way more than he'd ever walked. He was doing this all at night when they had limited staff, and it didn't draw attention until he began sleeping during the day, and they asked us to take a look at his movement. We explained that he had been doing all of this at nighttime, and then he was too tired during the day to get up and wake up and eat. He did eventually fall. He developed a pressure ulcer, and he did die a few months thereafter. So that's one example of really an excessive change in behavior that isn't noticed, especially if it's at night when there's not a lot of staff and there aren't a lot of people there to observe. And then based on our focus groups, clinicians would benefit from the subjective and continuous monitoring to supplement their decision making. It provides an objective element to this subjective behavioral type of phenotype that they have. Skilled nursing residents are a medically complex patient population, and clinicians are able to distinguish between normal and non-normal routines when they happen on a larger level, but they need help identifying the clinically relevant changes in specific behavior patterns, especially if those behavior patterns are not causing a problem. If they're not vocalizing, if they're not trying to escape, this objective system can really help. So to sum up, clinicians could utilize this objective patient information to make more informed decisions about the care plans, when to intervene, and to whom and how. Some references. And then I wanted to, of course, acknowledge the team of folks that have worked on these projects over the years, and the many, many data collectors and analysts and other specialists that have worked on this project as well. And most recently, the 26 clinicians, interdisciplinary group of clinicians who participated in our focus groups. And I'll try to turn my camera back on here if I can figure it out. That was a lot of me talking, so I hope there are a lot of questions.
Any questions for Dr. Bowen? Well, first, thank you so much. That was really, really fascinating. Well, I have a question while we are waiting for everyone
Sure.
else. So, do you envision that this sensor would be helpful, so 24/7 to any a skilled nursing facility and could be analyzed like almost immediately to provide this information, or maybe after one day to provide this information to the clinicians?
Right. So that is what we're working on now. We did the focus groups with clinicians to understand how they would use the information. When we show them the the information, what do they do with it? How would they want to respond? So the goal would be to work this into existing clinical workflow, not create something that they would have to do in addition to what they're already doing, but to provide that supplementary additional alert only when it's helpful. So of course, get rid of those false negatives and positives, and try to make sure they have confidence in the accuracy of the system. So the next step is analyzing it in real time, understanding each resident's baseline, and then analyzing it in real time from there to project when there has been a significant change with high sensitivity and specificity before providing that alert to the clinician. And then following them after they've received an alert to see what do they do with it. Do they go assess? Do they report it up? Do they have more confidence in, something significantly has changed? Or do they ignore it altogether? Because that would certainly be an option as well.
Yeah, there are so many factors that as you really emphasized, that are very difficult to capture and that are known by the clinicians. That's
Right.
that's really
It was
fascinating.
amazing. Yeah, it was amazing how much they kept in their head.
Hmm.
Because we don't do really regular assessments of function on long-term care residents. We have the MDS, but we really only do these after we do admission, a certain number of months, or after some sort of an event. And, for other patient populations, we do more assessments, a lot more often. And so we're just not getting that information because it takes so much time. And every clinician already has a heavy load. We're unable to do all of that. So really, we need something more automated to understand what's going on in these
Right,
facilities.
right. Any other questions?
Yeah, Colin, hi, it's Mina. I have a question.
Hey, Mina. Sure, go ahead.
And turn my camera on. Thank you so much for sharing this. I really enjoyed it because it actually is about applied work and how you implement something in the workflow. That's been something that I, as a researcher within a health system, struggle with. Like, if I want to use machine learning approaches, how do I do that when it's useful? And I can also actually implement it and communicate that with the health system. So you talked about why it's important to use machine learning, but also talked about the black box and how it's harder to interpret. So first, I would love to connect with you later to learn more about your experience. And second, what are your recommendations when we pick something, or like how can we communicate? Like, can you just elaborate a little bit on that? Like how we can choose these approaches that's really actually helpful, and how we can communicate it. I'm sorry if it's like a loaded question, but I really hope that we
No,
can.
I think that's good. So, in terms of picking an approach, we tried a couple of different approaches, and, initially what made the most sense was going to the literature, and there were all these observational studies about what they're doing and what they're doing before an event. And, some of these older adults have severe dementia, and they are more functional physically than they are cognitively. So they're able to walk around, they're able to try to escape, they're able to do, but they really can't tell you about it. And so there's really no understanding of why they're doing what they're doing. Are they experiencing a dementia progression? With veterans, are they experiencing an anniversary of something that's happened to them? Some veterans also, in addition to dementia or other conditions, they've got some TBI, some PTSD, some schizophrenia. There's all kinds of things going on in there, and so trying to understand why someone would be doing what they were doing when they really can't communicate has been very hard. So you go to literature and you do these observational studies and you say these behaviors were associated with this subsequent event, and then I think to figure out what we might be missing. these factors are all highly related. The time and distance walked is your gait speed, right? But we were finding that, longer distance walked is associated with dementia progression and a urinary tract infection or a delirium episode, especially like the hyper. So how do we figure out, which combination of these factors are associated with something important that we want to know? Because it's probably, and maybe some are more heavily weighted than others, right? And so instead of having these 5 things that our theoretical models are suggesting, there might be 2 that we really need to pay attention to for UTIs. And I think that's where, so it really, I guess to answer your question, it goes back to your research question. I think you usually want to start with the literature, and even if you're using machine learning, that should be grounded in the literature because it is a black box, and you have to be able to figure out what you got when it pops out. And so we were able to classify those 5 clusters because of the literature and pulling up the instances that 90% this is the behavior for 90% of the time for this person, and this is the behavior for 10% of the time for this person. And then you just look at your data and you say, well, it's all sedentary behavior. And these people who were very sedentary and then changed to highly active, that's a big change for them. What's going on? And then you can relate it to those acute events of interest. So I think you have to always look back to what the literature says. And then if you're using something like random forest and you have 150 factors and it ranks them, you could get like the top 5 could make absolutely no sense to you unless you have some sort of an understanding of why that may be related to what you have. Now we did random forest and we put everything in. We put the Barthel and we put wheelchair and age and we put different clinical assessments that they had in the chart. And our top 5 ranked were our sensor measures, which is good. But that's not always going to be the case. But yes, I'd be happy to connect with you. Just send me an email and we can have another chat about it.
I think there is a question in the chat.
Oh, that's an interesting question. Hi, Brianna. So we have mostly been looking at the acute events in skilled nursing that are associated with a very quick decline in function. We haven't looked at some of these other factors. We're starting to get more into respiratory, even COVID-19, because that's probably predictable. People probably have ambulation and behavioral changes prior to a COVID-19 diagnosis, which could be important for isolation, treatment, and other things in these facilities. I think strokes and other conditions, I am sure that there is an application for that. In fact, I think when this moves beyond the research stage to the clinical application, it just becomes, in some of these facilities, it would be nice if this just became the standard of care, that they wear these wrist-worn devices while they're in these facilities. I think a lot will probably come out of that in terms of, what specific conditions may be associated with. In research, when you have a sample and you get 25% of a unit, you're not going to have very many events. And if we don't have very many events, it's difficult to predict precursors to those events. But I do think that you're onto something, and I'm sure that any behavioral change from the norm would be important. And then it would be trying to figure out what is that associated with. And that's where the clinician experts come in. That's where the nurses would come in and do their assessments and say, oh, this is what's going on.
Any other questions? All right. Well, I don't see any other questions. Well, thank you so much for this extremely interesting and very thought-provoking talk. I can't wait to hear the next thing, your next results, and see whether it can be implemented, clinically. I think that'd be really fabulous. So in the next few years, right?
Yes,
That's what
research
you
process
think?
is slow, but yes, we're in the process of doing some feasibility and acceptability types of studies because to
Oh,
move from
great.
research to clinical
Right.
translation, right, and implementation, you have to know that the clinicians want it, accept it, and it's not going to be an undue burden for them to start utilizing this additional information. So those are the next steps.
So when do you think this will be done?
I don't know.
Oh, okay.
I don't know. I'm hoping in the next couple of years we will have a
Okay.
clinical alert system in these facilities.
Great. So you'll come back in a couple of years to
There you
tell
go.
us all
I'll let you
about
know
it.
how many we prevented. That I would love to do that.
Oh, that'd be great. All right. Well, thank you so much again, and
Thank
we'll
you.
talk soon.
Thanks for having
Thank
me.
you.
All right. Bye-bye.
Bye.